Welcome to Dental XP's Literature Review Series. I'm Dr. Henry Salama, and in this ongoing series, we will endeavor to review contemporary literature that has real clinical significance for us. We invite you to comment on the review, share your own take, ask questions, or share ideas for future research. Today, we will undertake to review current articles related specifically to our knowledge of the dimensions of the facial bone wall in the anterior maxilla, and our treatment of potential extraction sites, and how they may relate to implant therapy. As clinicians, when we look at extraction sites, we ordinarily attempt to ascertain the risk profile for that site. Very often, our perceptions are filtered through the prevailing conventional wisdom. This conventional wisdom is really based on only a few studies. Among them, Spray in 2000, Belzer and co-workers in the consensus paper for ITI in 2007, as well as Kahash and co-workers in 2008. These papers seem to believe that 2 millimeters of labial plate thickness is the ideal minimum to ensure proper soft tissue support and minimize resorption of the facial bone as well as recession. Is that true? Is 2 millimeters the critical point above which tissue architecture is stable around an implant and below which it's not? And is the correlation absolutely direct? And that's what we will examine. In a paper by Nozari, published in Clinical Implant Dentistry and Related Research in 2012. The team utilized CBCT and attempted to determine the prevalence of facial bone with a width of 2 millimeters or more. Again, obviously looking at that critical 2 millimeter osseous dimension of thickness. And they measured this thickness at the mid-root level. They took a perpendicular measurement to the long axis of the root and measured that bone right in that area. When doing literature review, it's important to notice where the measurements were taken, and we will actually compare this to measurements that are taken in subsequent studies and how researchers attempted to take several measurements along the length of the root and of that labial plate of bone. In Nozari's study, of the 202 teeth analyzed, only 3% represented that sought after critical 2 millimeters or more of labial bone thickness. It really gives us reason to pause and try to see what that relationship is. If only 3% of teeth actually have that critical 2 millimeters prior to potential extraction, what does that mean to our diagnosis, to developing a risk profile, and in fact to our treatment design? Conventional wisdom in dentistry, both in periodontics and restorative dentistry, has always related biotype directly with the thickness of the labial plate of bone. In addition, when we look at biotype, we tend to think of tissue architecture, both bone and soft tissue morphotype, if you will, or architecture. First, let's take a look at the bone in the literature, that bone morphotype. And this was only described by Bill Becker and co-workers in 1997 in a study of skulls that was defined in 3 categories: either flat, scalloped, or pronounced scalloped. This is important because looking at the osseous, they looked and described these in terms of architecture of bone, but they really had no relevance to the thickness of the bone. No effort was actually made to look at that time. Earlier in 2014, Zviers and co-workers published a systematic review in the Journal of Clinical Periodontology on the characteristics of periodontal biotypes. In essence, they looked at more than a couple of thousand papers trying to see critical ones that gave us significant relationships that we can work with. They were able to identify 3 biotypes, and those were thin scalloped, thick flat, and thick scalloped. And you can see how that relates really to some of the underlying characterizations that Becker in 1997 made on the bone morphotype. In another paper by Cook and co-workers in the International Journal of Periodontics and Restorative Dentistry in 2011, Cook actually went and looked for a direct correlation, and they were among the first group to attempt to relate clinical periodontal biotype with the thickness of the labial plate. A really very important point and very critical article. Their research did in fact provide the first human evidence to support the clinical impression that a thin biotype is associated with a thin underlying labial plate, and that a thick or average biotype is in fact associated with a thicker labial plate. So this was among the first evidence that yes, you can look at the overlying soft tissue architecture, and especially the thickness or thinness of that tissue, soft tissue, and that you should in fact expect a direct relationship with the thickness of the underlying bone. In addition, they also showed a direct relationship between biotype with alveolar crest position, keratinized tissue width, and probe visibility, meaning the ability to see a probe in the sulcus of thin tissue. This was described by Joseph Kahn in earlier work. Specific to this review, and I think as I mentioned earlier in relating it to the work by Nozari, if you take a look at the graphic at the middle of your screen, they did some really excellent work. They looked at 4 millimeters between the CJ and the alveolar crest, a critical number because in most healthy humans it's been shown that the CJ is about 3 millimeters away from the height of the crest of bone. So if you start out at 4 millimeters, you're more certain to take a very critical thickness of bone in that area. You're not going to get that very thin tip, but enough to get a general idea of what's going on. They also looked at 6 millimeters from the CJ, 8 millimeters, as well as 10 millimeters. And critically, when looking at the measurement specifically of that 1 millimeter from the crest of bone or apical to the crest of bone, the mean labial bone thickness for thin biotype was only 0.34 millimeters. While for a thick biotype, the mean thickness was 0.75. While statistically significant, and certainly that was part of their conclusion, when I look at this paper, I see that both thin and thick biotypes in fact exhibited a mean labial bone thickness that was less than 1 millimeter. Again, less than 1 millimeter. And going back to that critical 2 millimeters that we are looking for, certainly they've shown here that while there is a correlation between tissue thickness or thin biotype and thin measurements of the bone and thick biotypes and thick measurements, there's still both of them well below that 2 millimeter mark. In fact, it's even below 1 millimeter in thickness. To follow that, in a paper by Brout and co-workers published in International Journal of Periodontics and Restorative Dentistry in 2011, they also utilized CBCT to look at the anterior maxillary bone wall dimensions. So we're looking at several articles trying to see if in fact they're finding similar relationships. In the study, they reviewed CBCT and took measurements at 2 points. And this first points, they called it MP1, measuring point 1, was taken 4 millimeters apical from the CEJ, similar to the Cook article mentioned earlier. And their second measurement was taken at mid-root. When they looked at these measurements, and I wanted to highlight specifically for you the central incisor, that in fact, at measuring point 1, 4 millimeters apical to the CEJ, the bone for the central incisors was missing 27.5% of the time. At that same measurement of MP1, 67.9% of cases had a bone wall thickness that was less than 1 millimeter. In fact, only 4.6% of patients exhibited labial plate thickness of 1 millimeter or more. And that's a very significant finding, and certainly correlates with the finding of the Cook paper that was referenced earlier. In fact, taken all together, approximately 90% of patients exhibited a missing or thin labial plate of bone. Hyun, Ba, and co-workers in COIR, or Clinical Oral Implant Research, in 2010 also analyzed the socket bone wall clinically during immediate implant placement. So previous to this, we looked at CBCT measurements. Here in Hyun, Ba, and co-workers, they actually took measurements during intraoperative work, and they utilized calipers to take those measurements and to measure the thickness of the walls after the tooth was extracted. If we look at, and it was a very well designed paper, the aim of the paper was to determine the dimensions of the bony wall at extraction sites in the aesthetic zone, anterior teeth and premolars in the maxilla, and related to immediate implant placement directly. The methods were that they, as part of an ongoing prospective, randomized, controlled, multi-center clinical study on immediate implant placement, they measured the width of the buccal plate in 93 extraction sites. The results was that the mean width of the buccal and palatal bone walls was 1 and 1.2 millimeters. Now, they measured both buccal as well as palatal, but I'm going to concentrate mostly on the labial bone walls. And if you take a look at that in the anterior sites, not the premolars, but in the anterior sites specifically, 87% of the buccal bony walls had a width of under 1 millimeter. And this starts to becoming, if you look at several articles now, this starts to becoming a recurring theme. You're around that 87, 85, 90% of patients have thickness of bone walls that's 1 millimeter or less. And only 3% of the walls were 2 millimeters wide. So again, similar to Nozari's study, 3% actually fulfilled that critical 2 millimeter number that has been part of conventional wisdom in implant dentistry. Looking at their charting, if we look at the darker orange numbers, this is where you see it. 64% had 0.5 millimeter or less. The great majority actually had only 0.5 millimeter measurements. 23% had 1 millimeter. So taken together, you're looking at 87%. And only a very small number actually had that 2 millimeter thickness of bone wall. So critical to all this is that their conclusion that when incisors and canines were considered, only one site, 2.6% out of 39, displayed the 2 millimeter thick crestal labial plate of bone. And again, that really challenges our conventional wisdom that in fact 2 millimeters is a number that has to be there when we contemplate immediate implant placement. Is that really true? If it is, it would make it a lot of the work that we've seen clinically not possible. And that will stimulate discussion, certainly moving forward, on what that means from a clinical perspective. Our final article today is by Januario, published in Clinical Oral Implant Research in 2011. Again, they use CBCT to look at the dimensions of the facial bone. And this is going to certainly happen more and more so as almost all universities and research centers have access to CBCT, but also clinical practices. And we're going to be able to look at preoperative as well as postoperative results from our clinical practices and evaluate it in a lot more than we've been able to in the past. In Januario's study, their results again show that 50% of the sites they looked at had bone wall thickness that was equal to or less than just 0.5 millimeter. And I think this is a repetitive theme, certainly, that we can take away from these studies. And their conclusion, in a way, summarizes what we've seen, that most tooth sites in the anterior maxilla have a thin facial bone wall, and that, in fact, this thin wall has a risk of undergoing dimensional diminution following tooth extraction. This fact must be considered before tooth removal and the planning of any rehabilitation in the anterior segment. So as we look at these results and as we start to really see how do they affect our clinical decisions, we can summarize. These are the studies that we looked at today. Nowzari in 2012, Spheres in 2014, Cook in 2011, Brout in 2011, Hyun-Ba in 2010, and Januario in 2011. All of these studies really seem to give us a collection of, I think, enough breadth to give us information that we can really utilize, at least for now, and try to package it in a way to direct our clinical treatment and to maybe come up with a discussion to look at for what future research will look like. The takeaway for me, at least, and I'm looking to see what it means for many of the viewers out there in the community of Dental XP to have discussions about, is that if 2 millimeters of labial bone thickness is indeed necessary for long-term stability, as apparently the common wisdom in dentistry is today, it occurs in only a fraction of preoperative potential extraction sites. From all the studies, the average looks to be about 5% or less. That the great majority, 90% and more in some instances, and for some teeth in the anterior region, of potential extraction sites exhibit less than 1 millimeter of labial plate thickness. And finally, and this is very, very critical, I believe, that while there may be a direct correlation between biotype and labial plate thickness, for instance, thin biotype has thin labial plate and thick biotype has a thicker labial plate. Even the thicker labial plates for the thick biotypes, altogether, if we look at it, it does not seem to correlate with a labial plate that is greater than 1 millimeter. So in instance, while it may be thicker than the thin biotype, all of them seem to be less than 1 millimeter. One of the questions that I have, and certainly I'm interested in what you have as well, is it more important to begin with 2 millimeters of labial plate thickness or end with 2 millimeters? Because certainly in most cases in the anterior region, we are going to begin with 1 millimeter or less. So how does that factor in what we do with that thin labial plate? And I think that over the last 15 years, certainly we have altered our clinical approach to extraction and immediate implant placement to address that very thing. If the patients if a patient has a greater than 2 millimeter of soft tissue thickness post-operatively, measured at the crest of bone, is it still necessary to end with 2 millimeters of bone thickness in order to achieve that long-term clinical peri-implant aesthetic stability? Or are there different parameters that we need to look at? What does tissue thickness and how does that come into play in that equation? So I think these are all good questions. I hope we've stimulated some discussion and given you some information on this relevant research. Again, for this series to work, it really requires your participation and your feedback. We look forward to your questions, to your comments, and certainly to a lively discussion. Thank you very much.